So we'll begin the first session, and the first speaker is Dr. Swapnil Pathak. He is a brief introduction. He's MBBS from Eras Hospital, DNB, Pulmonary Medicine. Currently, he is working at the Max Super Specialty Hospital, New Delhi. He has done his fellowship in respiratory medicine, and he's associate director at Breathizi Hospital. He's going to talk on the introduction to the interventional pulmonology. So we invite Dr. Swapnil Pathak to start the session with his talk.
Thanks a lot, sir, for this brief introduction. So, hello and good evening to all the guest speakers, chairpersons, panelists, and our delegates. It's really my pleasure to speak in front of you all. It's my immense pleasure this time to welcome my mentor and my guru, Dr. Vivek Nangia, into this RCC this year. So, the topic that has been allotted to me is a brief introduction to intervention pulmonology. So, details regarding this topic will be discussed and dwelled with my other seniors in the next subsequent sections. So let's just begin with this topic. So interventional pulmonology is quickly evolving subspecialty of pulmonary medicine, offering minimally invasive procedures for the mediastinum, lungs, airway, and pleura. The range of procedures includes diagnostic and therapeutic options for both benign and malignant diseases of the lungs. Imaging plays a key role in identifying patients who will benefit from intervention pulmonology procedures, detailing the relevant anatomy and measurements for procedures planning and monitoring patients for successful outcomes and complications related to these procedures. So the contents of this lecture will be, so I've divided this kind of a topic in two parts. The one are basic procedures that are dealt in pulmonology, and another is advanced procedures in pulmonology. So I'll go one by one. With respect to basic procedures, there are USG guided needle thoracocentesis, pleural tap, chest tube insertion, flexible fiber optic bronchoscopy, medical thoracoscopy / pyroscopy, can be rigid, can be flexi-rigid, ultrasound or CT guided percutaneous transthoracic needle biopsy. And in advanced procedures, there are certain procedures like IPC, indwelling pleural catheterization, cryo techniques in pulmonology, therapeutic bronchoscopic interventions, curvilin probe, EBUS guided transbronchial needle aspiration and transbronchial mediastinal cryobiopsy, and radial EBUS, autofluorescence bronchoscopy and OCT of airways, navigational bronchoscopy, augmented fluoroscopy, virtual bronchoscopy, and robotic bronchoscopy. These are certain newer things that have been evolving in branch of pulmonology. So ultrasound guided needle thoracocentesis or pleural tap. So I'll just briefly talk about the indications of all these procedures. So there are certain diagnostic indications to determine nature, that is exudative versus transudative, and potential cause of pleural effusion. Therapeutic, that is large volume thoracocentesis to be done in cases where moderate to large pleural effusion is there, causing dyspnea, hemodynamic instability. Chest tube insertion, what are the indications? Pneumothorax, can be primary spontaneous pneumothorax, persistent or recurrent after simple aspiration. Secondary spontaneous pneumothorax, tension pneumothorax after initial needle aspiration in any ventilated patient if there is a pneumothorax. Malignant pleural effusion, empyema and complicated and parapneumonic pleural effusion. Traumatic pneumothorax, post-operative cases, example after esophageal or cardiac or pulmonary surgeries and pleural surgeries. Mediastinal or pleural surgeries. Treatment with sclerosing agents, or that we call pleurodesis, can be with the help of chemical agents, can be with the help of talc. Post-pneumonectomy BPF cases. So third one is diagnostic flexible fiber optic bronchoscopy. So certain indications as in for evaluation of signs and symptoms like hemoptysis, stridor, unilateral wheezing, hoarseness of voice, unexplained chronic cough. For infections of evaluation and diagnosis of infections like pneumonia, immunocompromised host, non-resolving pneumonia, cavitatory lesions. For DPLDs like ILD, diffuse alveolar damage and hemorrhage, drug-induced lung disease. For evaluation of certain malignancies like lung nodules of mass. For other airway disorders like extracting mucus plugs and all. Foreign body aspiration, benign airway strictures. So Of course, most of them are diagnostic, and few of them are also therapeutic interventions. In case of ICU, bronchoscopy guided intubation as in difficult airway, endotracheal tube position, we can take the guidance of fiber optic bronchoscopy in it, and certain other miscellaneous cases. So, what is so medical thoracoscopy or pleuroscopy? There are certain indications of this kind of a scope which goes into your intercostal space, and for evaluation diagnosis of undiagnosed exudative pleural effusions, staging of lung cancer with pleural effusion, and staging of malignant mesothelioma, thoracoscopic talc quadrage for recurrent malignant pleural effusion. So what's this? This is ultrasound guided or CT guided percutaneous transthoracic needle biopsy. Although this kind of procedure is dealt with interventional radiologists nowadays, but we can also go with this procedure. What we do exactly is it's indicated in evaluation of solitary lung nodules and masses, mediastinal and hilar lesions, metastatic diseases to lung from a known extrathoracic malignancy, chest wall invasion by lung carcinoma, pulmonary consolidation or infiltrate that are likely to be of infectious origin. So what is important with respect to this ultrasound or CT guided percutaneous transthoracic needle biopsy is that for peripheral pulmonary lesions, we usually go for this. So what are the advanced procedures in pulmonology? So one is IPC, indwelling pleural catheterizations. It's indicated in the condition where patients with malignant pleural effusion with or without non-expandable lung. So in this situation, we can go for IPC. Rapid accumulation, that is within 1 month after large volume thoracocentesis. In these cases, we can offer IPC. Patient who has failed pleurodesis and does not prefer a repeat pleurodesis. So that is very important in patients when there is a failed chemical pleurodesis or a talc pleurodesis, we can offer these patients IPC. So there are certain cryo techniques in pulmonology. So basically, the cryo, this is a cryo technique which has a principle which I will not deal with right now. So there are certain methods: cryoablation or destruction, cryoadhesion or extraction, cryobiopsy, as in TBLC using 1.9 mm probe, or TMC, that is using 1.1 mm probe, and cryo recanalization. So I'll specifically focus on cryobiopsy, that is very commonly used nowadays. So the uses are endobronchial cryobiopsy during bronchoscopic resection or recanalization, TBLC for diffuse ILDs, and TBMC for mediastinal lymph nodes. With respect to TBLC, although original observational studies suggested that the rate of complication was low, that is less than 5%, subsequently studies report that higher pneumothorax and bleeding rates than standard transbronchial biopsy. So that is what the difference is in transbronchial cryobiopsy. The complications are comparatively lesser than the conventional transbronchial lung biopsy with the help of a forceps. So if we can see this this console, it has got a cryogen cylinder which contains pressurized carbon dioxide, N2O or liquid nitrogen. A cryogen cylinder then delivers this gas into this this cryo console, and then after this cryo console, it ultimately transfers to the cryo probe where we are kind of going to get a biopsy from. And there's a foot pedal which we can use to deliver the gas. It kind of a pressurized gas delivers at a particular focus, kind of freezes there, and then so freeze and thaw kind of a principle. We freeze a tissue and then we thaw. Sometimes we freeze and extract, sometimes we freeze and then we thaw and then take the tissue. So with respect to different kind of procedures like cryoablation and cryoadhesion or cryobiopsy, different techniques can be used. So therapeutic bronchoscopic interventions are also available nowadays. So I'll quickly talk about these. So rigid bronchoscopy and its diverse therapeutic role. Flexible bronchoscope has to a larger extent replaced the rigid bronchoscope for most diagnostic and some therapeutic indications. Rigid bronchoscopy still has got some vital role with respect to intervention pulmonology. So the indications of therapeutic, this rigid bronchoscopy allows a number of therapies such as endobronchial laser, photocoagulation, placement of endobronchial stents, silicone or SEMS, endobronchial balloon dilatation, electrocautery, organ photocoagulation, that is APC, cryotherapy, brachytherapy, photodynamic therapy to be performed safely and effectively. So these are certain therapeutic procedures that can be performed via a rigid bronchoscope. So If you can see that this is balloon tracheobronchoplasty. Using an electrocautery incision we made into the benign stenotic lesion. So there was a stenotic lesion which was benign. So one has basically entered into the airway using this balloon, and they kind of dilated this narrowed stricture. This is endobronchial silicon stent placement, in which we can see there's a large tumor nearly completely obstructs the tracheal lumen. So there was a manual debulking which was performed by a rigid bronchoscope, and then which ultimately improved the luminal diameter of the airway, and then we placed the endotracheal silicon stent which into the trachea. Bronchoscopic lung volume reduction in advanced COPD cases. So basically indicated for heterogeneous emphysema, which is bilateral upper lobe predominant on CT scan. So there are certain techniques by which we do bronchoscopic lung volume reduction. So this is not a surgical lung volume reduction, this is bronchoscopic lung volume reduction. So there are three principles: targeted lobe atelectasis, either using a one-way endobronchial coils or self-activating endobronchial valves. And second principle is targeted destruction and remodeling of the emphysematous tissue using bronchoscopic thermal vapor ablation and lung sealant. So basically it's a airy seal kind of a thing which is sprayed into the airway, and then it kind of destructs the emphysematous tissue. And third, the principle is bypass tract stenting or transpleural ventilation using endobronchial stents. So I'll quickly show the images. So these are Zephyr endobronchial valves and this spiration valve system. Bronchoscopic thermal vapor ablation, endobronchial coils that we can see on the chest X-ray. Multiple coils are placed in the I think right upper lobe. BLVR stents. So as you can see, so this bypass stent is very small. It's like a pencil tip, kind of bypasses the airway tract. This is a lung sealant, airy seal system, goes and destroys the airway. Bronchial rheoplasty is a technique. So this is not part of BLVR, but bronchial rheoplasty and targeted lung denervation are also used techniques for advanced COPD cases. So my seniors will deal with all this thing in the subsequent lecture. This is liquid nitrogen metered cryo spray, Rejuven Air. Bronchial thermoplasty for patients with severe asthma. It is also kind of based on basically high temperature goes there and ablates the mucosa of the airway for the severe asthma patients. So I will not deal with the concepts of all these procedures, where are indicated, what are the indications, contraindications, and the concept and principles behind it. But I'm just giving an overview of all what all happens in IP basically. So this is EBUS TBNA and TMC. That is what. So indications are. So this is a special kind of a bronchoscope known as EBUS scope. It can be a curvular probe EBUS, can be a radial probe EBUS. We can go there. We can take pass a needle and take a aspirate from a mediastinal lymph node, which is suspected to have some either malignant or non-malignant disease, and we can also take a biopsy from those nodes also. So what are the indications? Evaluation, that is sampling of mediastinal masses and mediastinal and hilar nodes that are more than equal to 1 centimeter using EBUS TBNA, EBUS TMC or EBUS IFB. Diagnosis, staging and restaging of lung cancers, especially for non-small cell lung cancer. Evaluation of pulmonary nodule, endobronchial or peribronchial lesions to guide therapeutic interventions, example airway stenting. So this is our radial probe EBUS. So basically goes inside and gives a 360-degree view of the airway. So this is EBUS transbronchial mediastinal cryobiopsy. I have already discussed the cryobiopsy principle, in which we can use a probe that is 1.1 mm. It can go inside, take a biopsy from the mediastinal lymph node. So as we can see, the hyperechoic structure which is inside the node, which is basically a cryoprobe. So we can even evaluate a tracheobronchial mucosa using certain dyes. This is called as autofluorescence bronchoscopy. There is also airway OCT that is available to look at the various layers of the airway, the mucosa, submucosa and all. So this is called as airway OCT. As we've already heard of ophthalmology. In ophthalmology, the OCT are used basically to evaluate the layers of retina. Similarly, we can use the airway OCT for this. So these are all bronchoscopic techniques. So In the last, there is bronchoscopic evaluation of SPN and peripheral pulmonary nodule. There has been a continuous emphasis on the improving the ability to access and sample peripheral pulmonary nodule through technological advances in electromagnetic navigational bronchoscopy, augmented fluoroscopy, and virtual bronchoscopy. Furthermore, these guided bronchoscopy techniques can be combined with each other using ultra miniature radial probe EBUS, guide sheets, ultra thin bronchoscopes, and most recently robotic bronchoscopy systems. So basically, peripheral pulmonary nodule, it's a broad kind of a topic which basically we can go for a transbronchial transthoracic biopsy via ultrasound or CT guided. We can also go via the bronchoscopic technique, but it's kind of very difficult to localize that nodule and to take us appropriate sample from that nodule, because without these kind of systems which are available now, just with the radial probe we cannot exactly know that whether the so first of all we go inside, take a localize the nodule with the help of radial probe EBUS, and then we kind of come out with the radial probe, and then we again go with the help of this biopsy forceps, and then blindly take a biopsy. We don't know basically whether the biopsy which was taken was from the nodule or not, from exactly the nodule. So these systems are basically useful. So use of a virtual bronchoscopy based system for navigation. So this A is a chest CT image of a speculated left upper lobe pulmonary nodule. B image shows a 3D reconstruction of the tracheobronchial tree with the nodule identified. And C is virtual bronchoscopic image, that is endobronchial virtual bronchoscopy image of that particular nodule from the in that subsegmental level. And then with the help of this bronchoscopy, this is a robotic bronchoscope which can be used, but not really available in India. But these navigational bronchoscopic systems are available that we in this we can integrate the CT scan of the picture and kind of localize the nodule and then take a sample from there. So this is the virtual bronchoscopic navigation system. So thanks a lot.
Thanks, Swapnil. I have a small query before we open to the audience. And I was looking the list very precisely. We internist physicians face quite often problem of post-tubercular bronchiectasis. In spite of good anti-tubercular treatment in the past, these patients, they keep on coughing blood infrequently, frequently. And initially the surgeons used to perform. So what is the role of now minimal access surgery which Sanjay might be doing, or with these instruments? How frequent we are able to pick up? Because they have a destroyed bad lung, the bronchiectasis, either you go for the pneumectomy, which is a difficult procedure, and most of the time they are not opted for. I have Dr. Jauhari with me, and I keep on troubling him also with such patients. Where is the role of this new procedure, EBS, or maybe minimal accessible surgery?
So you were asking about the bronchiectasis patient?
Bronchiectasis recurrent, these patients keep on coughing blood. So either you do good angiography and try to pick up the blood vessel and then try to thromboize.
So for diagnostic purpose or therapeutically?
Yeah, I want your answer with any one of these instruments.
I think bronchial thermoplasty can have embolization. Okay.
I said that, but okay. Often even it doesn't work.
So basically, sir, that would depend on the extent of bronchiectasis that is there. If it is localized to one lobe, the other lung is healthy, patient is fit for surgery, and it's recurrent infections, recurrent massive hemoptysis, then yes, the patient should be operated, and that will give them a lifetime cure for it. But if it is bilateral disease, lungs are poorly damaged, poor lung reserves, cardiac issues, other comorbidities, then the patient will be unfit for surgery. So basically you have to see at the extent of bronchiectasis and the fitness for surgery. And of course they can do a lobectomy, they can do a segmentectomy, pneumonectomy is not done now unless it's like really extensive and really causing a lot of problem. But yes, they can be operated.
Your experience?
Yeah, I agree, sir. The recurrent hemoptysis is very commonly the presentation of these cases. These cases are referred to us. But when the patient is stable and we really look at all the radiological diagnostic evaluation of those patients, based on that decision is taken. As you said clearly, that if it is a small area that is involved and we know that there's a focal lesion, then surgery is the option. we do take the help of the interventional radiology people as well, because if sometime it looks like the recurrent hemoptysis and patient is not really fit to undergo surgery, then in that case we ask the opinion of the interventional radiology if they can embolize those culprit vessel, and so that it can be cured. I have one question for you. This is about the endoscopic lung volume reduction using those endobronchial valve. So, we know it is because I've heard about it theoretically only, but majority of the time the cases are referred to us for lung volume reduction surgery. And I just, if you guys have experience on that, so I just want to know exactly how many, is it like a staged procedure? You do it in multiple sessions and use the valve selectively for those bronchial or whichever that emphysematous area is there.
So, endobronchial treatment of emphysema is another word for that. Yeah. So far, to the best of my knowledge, it is not available in India yet. But I do have experience using that in Europe. It is typically, it may be done in a staged manner also, depends on the target. But typically, we would not like, typically we don't like to do two sides at the same time, because the risk of pneumothorax is very high and you don't want the individual to land up with a bilateral pneumothorax. So typically, if you're thinking of doing bilateral, then it would be in a staged manner. On one side, you can do two lobes at a time. That's not a problem.
That's right. Because I always find the merit of having this endoscopic procedure, because those culprit areas you take care, and it allows the remaining normal lung to expand, so that the reduction takes place in a very effective manner. Because when we go surgically, we take out a lot of the bits which may be even normal looking lung, because unless we are sure that is only the emphysematous area. So that's the problem.
Basically what you need to see is whether this is a heterogeneous or a homogeneous emphysema, then whether there are collateral air channels available or not. If that is happening, then no procedure will really help except for surgical excision. If there is no collateral channel happening and it's a unilateral disease, again like a Buller's disease or a heterogeneous emphysema, predominantly the upper lobe disease, then they benefit with the use of all these endobronchial therapies, which may be in the form of valves or BTVA. BTVA is now available in our country, but again, very limited experience, because the selection criteria of these patients is very, very strict, and not many patients really fulfill that criteria. So, but endobronchial therapies are known to have better outcomes as compared to surgical outcomes in these patients, because most of these patients are moribund, they are end-stage lung diseases, they are unfit for general anesthesia, prolonged general anesthesia. So the comparison between the two groups has been seen to be better for the endobronchial therapy patients.
Thank you.
Okay, thank you, sir. So to present one question. Okay, please.
My question is, are you doing thermobronchoplasty in your center? And how effective is in severe asthma management?
There are a few cases with Dr. Angia, sir, tried severe asthma cases. Bronchial thermoplasty.
So we've done it in about 2 patients so far, had very good results, but then for some reason there has been a lot of controversy around the modality of treatment in these patients. And now the biologics are being used more than bronchial thermoplasty. So bronchial thermoplasty was classically reserved for patients who did not qualify for any of the biologics also. But then for some reason, we are still not very clear why it is happening. But thermoplasty does seem to have a lot of potential in management of these patients, but has gone out of favor for some reason. I guess Prashant would be able to highlight this better.
So for thermoplasty, I think it has a very good role, particularly, now when the thermoplasty trials were done, that time we did not have biologics. So it was, done for all patients who had severe asthma. Now there is some sort of a phenotyping. People who are qualifying for biologics, people who are not qualifying for biologics, or people who are failing biologics. So there is a role, selective role for thermoplasty. We've had good experience with thermoplasty. There has been the controversy is more from the industry side in terms of providing the catheters, etc., which are needed for thermoplasty. So, of course, a dominant number of patients who have severe asthma can do well with biologics, and of course, therefore, as I said, you have to phenotype them and identify which are that small subgroup of patients. See, severe asthma is a small subgroup. Within that, the individuals will qualify for thermoplasty is a small subgroup. It is a good modality in selected patients.
Thank you very much. So to present Angavastram and Memento to our young and upcoming Dr. Swapnil, I would like to call another young and dashing pulmonologist of Varanasi, Dr. Robin Dubey sir. Dr. Robin Dubey sir is not. I would like to call Dr. Vikas Jaiswal sir, another young and handsome pulmonologist of Varanasi. Thank you very much, Dr. Swapnil.